There were three messages that came with this talk last night. I realize you weren't all there, but there were three messages that came from this experience. So I thought I'd just scroll through these slides for a second to get to the meat of this discussion. And then, in the sense of learning, we need to learn from you, right? So let's see. This is the story of my husband, Brooke Hopkins, and we went all through this discussion about his serious spinal cord injury as the result of a bicycle accident, about everything that we knew about death and dying, about the travels we did, about the fun we had, about what we thought was wrong with our assumptions in healthcare and how how inadequately many of our traditional cultural assumptions undergird the kinds of decisions that we have to make these days, about his accident, about his living will, about hospitalization, and about home care. When we came to lesson number one. And lesson number one from this experience was that don't make friends with patients. Don't make friends with patients is really bad medical advice. And it's bad for caregivers, and it's bad for patients. So that's the first thing I'd like to talk with you about. Then we continued on through our life at home, about the good things, right, to lesson number two. And lesson number two was, look, this is really bad news, right? This is somebody who had been a vigorous, healthy, robust, intellectually lively, and just an all-around wonderful person. Breaks his neck, right? Paralyzed from the top of the shoulders down, on a ventilator or with severe respiratory much of the time. But the lesson here is, it's only a tragedy if you make it that way. Right? So what counts as a tragedy there, of course, the factual changes in situation, but it's the way you think about it that makes the biggest difference. So I'd like to talk about that with you too. And then we moved on to the downhill part, before his death and his death by requesting that his ventilator be discontinued, to lesson number three. Since we were talking about death and dying, you need a physician who listens to you, who understands you, and who becomes your ally, your helpmeet, indeed your friend in how to die. So I thought what we might do this morning here for a few minutes is think about answers to those issues as a way of being a learning system right here. So I'm open for discussion, right? This is questions. I have a few that people have asked me. One is about, this comes from social workers. What about the costs, right? There was a slide of the whole home care staff. The costs? Enormous. Enormous. Of course, there weren't any direct cost to us for the 2 years and 2 weeks, not counting later admissions, that Brooke was in the hospital. After a very modest copay, initial copay, that didn't cost us a dime. But once he was home, and you couldn't get and didn't want the kind of home care that would be provided, sparse, inadequate. Here's a guy with serious respiratory difficulties on a ventilator. We were told you couldn't have home vent service like that. That's all out of pocket. So what's the situation for people who didn't have a little nest egg that instead of traveling around the world or whatever else we would have done, you could spend on paying for 24/7 self-trained home care staff? That's about, we figured it between $180,000 and $300,000 a year, right? For a person who the length of time you cannot foresee in advance. Hardly anybody can do that. We were lucky. How should we think about that? So I'd appreciate some account of costs, because you're the ones out there who know what this is like for people who don't have nest eggs. How should we think about that? Second set of questions I have, and again, this is open for discussion. What were the worst things that happened in the hospital? Why don't we ask? We talk a lot about improving healthcare. We have to remind ourselves of the worst things that happened. So a lot of people here have experience in hospitals either as care providers or care receivers, or most frequently both. So I'd like to hear from you. I have some answers about what the worst things were in this case, but that doesn't mean there weren't worse things that happened elsewhere. And then finally, I thought we might talk about the role of palliative care in a situation like this, how important it was when we finally got it, right? And about chaplaincy issues and how they get perceived and who actually needed them and used them. So this is Q&A period. I know this wasn't in the plan, John, but it's the way I think of learning systems is to hear from you. Does anybody want to lob any questions over here? Yeah. Yes, sir. What exactly was the worst experience? Well, there were many misadventures in the hospital, including a near-fatal overdose of the conflation of opioids for pain and methadone for, this was a person who had no prior experience with any of these things. A number of patients actually died in that hospital in that couple of months before they figured out that they hadn't realized that long-term maintenance on methadone in palliative care and short-term use of opioids was not a good idea. But that wasn't the worst thing. The worst thing was chronic, right? And it was in every unit, every admission, every time. It was the beep, beep, beep from drip monitors, day and night. That noise occurs right next to the patient's bed. Now, who can do something about that? Not the patient. What can the patient do? Worry. What's wrong? Is it clogged? Is it overdosing? Has it run out? Right. That beep needs to be heard on the nurse's belt or the nurse's station, right? So that, if you count 2 years worth of beep, 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 or sometimes beep, beep, they all have different noises, right? That's one of the seemingly smallest things, not rocket science to revise, but something that when we think about quality of healthcare, it's not the great big stuff like the nearly fatal overdose. It's the little chronic, stupid stuff that we could fix, right? Yes?
I'd like to sort of complain about the lionization of hope.
Oh, yes.
Bad hope is just false hope. Brings so much pain to people who care, people who are already in pain, and the people who care for them. My father had multiple medical illnesses all of his life, and in the last decade, even when he had, kidney failure and diabetes and bone cancer, doctors would still say, well, you could try this radiation. I mean, it was like, why not sign up for Torquemada?
That's such an enormous question that it's impossible to answer beyond just noting the transition, the transformation in the role of hope in medicine. So if we're talking about the Middle Ages, hope in medical circumstances is not for this, it's hope of a better life beyond. Suffering now is perhaps the prerequisite for a life in bliss in a hereafter. But as those views, those metaphysical views change, we retain the sense of hope, but it's not clear what for, right? Anyway, you can say more than this. You just did say more than that, in that we need to be careful about what we think hope is for. Now, hope played a huge role in Brooke's flourishing in the middle of this, right? Hope of some decrease in pain, increase in some function, and hope of being able to be as nearly normal and functional, teaching, relationships with other people, that kind of stuff. But the kind of medical hope that you're talking about is, I think, a trap. Tell me when to stop. Okay. Okay. Yeah? Yes?
How was your spiritual care experience?
How was our spiritual care experience? After this injury, so Brooke was a pretty well-known guy around in the community because he'd taught at the university for so many years, had so many students in the area, former students. We all knew, lots of people. And after his injury, so here he is in bed, totally paralyzed. All the divines showed up, right? The minister of this, the rector of that, the priest here, the so-and-so there. These were, by and large, people we knew, we cared about, we interacted with. And they all brought the spiritual encouragement that they had to offer. And we were tremendously grateful for that. But of course, some of it didn't really entirely speak to us, either because it involved hope of a better afterlife or something else, except for one. And the divine who came, if you can use that term in jest, was actually the Buddhist Lama, who came and said, it was a wonderful scene. He came first, so Brooke's still in the hospital step-down unit, right, from the ICU. He came, he's very great, big, very erect and wonderful man with this glow about him. And he came in his maroon and saffron robes, right? And of course, there are about 6 white-coated doctors in this room. And he comes striding in, not arrogantly, just with this poise and grace. And they all shrink because here's Western medicine, as it were, on the ropes before this figure of insight, I guess you'd say. And he said, well, the body is nothing. It's the mind that counts. Brooke's mind was perfectly intact. But he said, don't dwell on what you've lost. So no more hiking, sailing, biking, traveling, dancing, sex, any of those things, right? And don't worry about the future. It isn't here yet. Think about, in Buddhist language, the present moment. And that was the single best piece of spiritual advice, if you can call it that. That made a difference. And the other spiritual event was when he was actually at home in the process of having the ventilator withdrawn by the hospice doctor, the hospice nurse, and 2 of our respiratory therapists. So he's at home, in the process of dying. And the hospice doc had said, you know, we have chaplain services, and would you like us to ask the chaplain to come? And we hadn't been particularly religious, so we said no. But as time went on, you noticed that the chaplain was there, right? And later, it turned out, well, there was a lot else going on, so you didn't pay too much attention to it. It turned out that the hospice doctor had called the she apologized profusely. We said, no, I said, no problem at all. She needed the chaplain for herself. We forget about the spiritual needs and vulnerabilities of people in healthcare.